هستكمل سلسلة البيسك دنتال implant course. CBCT and dental implant. How can I use it? I can use it in the identification of vital structures, calculation of distance measurements, determination of bone density. Now we will discuss some anatomical consideration in relation to dental implants. First, at least 2 millimeters should be present between the implant and the inferior alveolar canal. At least 1 millimeter should be present between the implant and the maxillary sinus or nasal cavity. At least 5 millimeters should be present anterior to the anterior border of the mental foramen to avoid the inferior alveolar nerve looping if present. At least 1 millimeter should be present between the implant and the inferior border of the mandible. At least 1 to 1.5 millimeters should be present between the implant and the buccal or lingual plates of bone, here and here. At least 3 millimeters should be present between the adjacent implants, here, here, here. I should have 3 millimeters present between adjacent implants. Bone types. The bone density may be determined by tactile sense during surgery, the anatomic location, or radiographic evaluation by CT. We have 4 bone qualities for the anterior region of the jaws. Quality 1 is composed of homogeneous compact bone. Quality 2 has a thick layer of cortical bone surrounding dense trabecular bone. Quality 3 has a thin layer of cortical bone surrounded by a dense trabecular bone of favorable strength. Quality 4 has a thin layer of cortical bone surrounding a core of low density trabecular bone. So, type 1, usually found in the anterior mandible, difficult to drill, become overheated, and slow impaired healing may result. Best type of bone regarding initial implant stability, suitable for immediate loading. Type 2 or D2, thick layer of cortical bone surrounding a core of dense trabecular bone, usually found in the anterior mandible, posterior mandible, and anterior maxilla. Most preferred type of bone since it provides good initial implant stability, suitable for immediate loading. Type 3, thin layer of cortical bone surrounding a core of dense trabecular bone, usually found in the posterior mandible, anterior maxilla, and posterior maxilla. Provides a good initial implant stability. Type 4, very thin layer of cortical bone surrounding a core of loose trabecular bone, usually found in the posterior maxilla. Worst type of bone as it neither provides initial implant stability nor allow immediate loading. If I don't have a CBCT, I can use panorama, but it has the disadvantage of magnification and 2 dimensions and ridge mapping. Treatment planning. What prosthetic options do I have? Of course, I have fixed prosthodontics and removable prosthodontics. I have 3 types of fixed prosthodontics and 2 types of removable prosthodontics. First, the fixed prosthesis. I have FP1. FP1 is a fixed restoration and appears to the patient to replace only the anatomical crowns of the missing natural teeth. To fabricate this restoration type, there must be minimal loss of hard and soft tissues. The volume and position of the residual bone must permit ideal placement of the implant in a location similar to the root of a natural tooth. Type 2 or FP2 appears to restore the anatomical crown and a portion of the root of the natural tooth. The volume and topography of the available bone is more apical compared with the ideal bone position of a natural root. Prosthesis has longer clinical crowns than healthy natural teeth, as you can see here. The soft tissue drape is also reduced around prosthesis. The high maxillary lip line during smiling is noted before fabrication of the prosthesis. When the upper lip during smile does not expose any of the interdental papillary regions, an FP2 prosthesis may be fabricated. FP3 or type 3 replaces missing crowns and gingival color and portion of the edentulous site. Prosthesis most often uses denture teeth and acrylic gingiva, but may be porcelain to metal. Here, an intraoral review of this FP3 restoration shows how it replaces the interdental papillae with pink porcelain. The high lip line during smiling shows the interdental papillary regions in the anterior maxilla. The fixed prosthesis should replace the gingival regions in the aesthetic zone by soft tissue surgery or with the final restoration. Here an FP3 prosthesis with pink porcelain. Now I will talk about removable prosthesis. There are two kinds of removable prosthesis based upon support of the restoration. RP4. It is a removable prosthesis completely supported by the implants, teeth, or both. Usually 5 or 6 implants in the mandible and 6 to 8 implants in the maxilla are required to fabricate completely implant-supported RP4 prosthesis in patients with favorable dental criteria. An RP4 restoration is a removable prosthesis, usually an overdenture. This is completely implant-supported. In this patient, the mandible restoration has 5 implants between the mental foramina and a cantilever bar to the posterior regions. The prosthesis is rigid and therefore requires attention to implant position and an implant number similar to an FP3 restoration. So the second type is RP5. It is a removable prosthesis combining implant and soft tissue support. As a summary, fixed restorations have 3 categories: FP1, FP2, and FP3. The restoration type is related to the contour of the restoration. FP1 is ideal, FP2 is hypercontoured, and FP3 replaces the gingival drape with pink porcelain or acrylic. The difference between FP2 and FP3 most often is related to the high maxillary lip position during smiling or the mandibular lip position during sibilant sounds of speech. FP2 and FP3 restorations often require more implant surface area support by increasing implant number or size or by adjusting design considerations. Removable restorations have 2 categories based on implant support. RP4 prostheses have complete implant support, anterior and posterior. In the mandible, the superstructure bar often is cantilevered from implants positioned between the foramina. The maxillary RP4 prosthesis usually has more implants and little to no cantilever. An RP5 restoration has primarily anterior implant support and posterior soft tissue support in the maxilla or mandible. Often fewer implants are required and bone grafting is less indicated. Treatment planning. First, implant selection. Length, width, and finance, and so on. Implant techniques. First, delayed implantation. Implant inserted in a healed extraction site after at least 9 months from extraction. The disadvantage is it allows bone loss to occur after extraction. Immediate implantation. Implant inserted immediately into fresh extraction site, but there are some rules. First, absence of infection, automatic extraction, drill parallel to long axis of tooth, and always put the implants toward the palatal plate of bone. Here a case of immediate implantation. Then we have delayed immediate implantation. Implant inserted in extraction site after 2 to 8 weeks of extraction. The indication: periodontally affected teeth and the presence of pus. Loading techniques: immediate loading and immediate aesthetic restoration. Immediate loading: implant is inserted and the abutment is immediately loaded over the implant. Immediate aesthetic restoration: impressions taken to fabricate a temporary acrylic crown, and of course it will be out of occlusion, and patient is instructed to eat soft diet. Delayed loading: a healing period of 3 to 4 months for osseointegration to occur, and then a final restoration is loaded on the implant. 2 stages versus 1 stage. First, I will talk about 2-stage surgery. First, implant is inserted and covered by a healing screw, and then the flap is sutured back. Second stage, after the healing period, The healing screw is exposed and removed, and a healing abutment is placed instead to allow healing of the gingiva around the implant. The two-stage surgical approach offers several advantages, like direct observation of crystal bone volume before osteotomy and direct observation during osteotomy preparation, and the ability to bone graft the site at the time of implant placement, and so on. The implant is inserted at or slightly below the crest of bone in this technique. A low-profile cover screw is then inserted into the implant body. The tissues are then approximated over the implant for primary closure. The one-stage implant healing abutment is placed after insertion of the implant. The advantages: better soft tissue healing and aesthetic outcome. The one-stage surgery uses a similar incision and reflection technique to observe directly the crystal bone volume. However, at the conclusion of the implant surgery, a permucosal healing element, PME, this one, is placed into the implant body. The implant body also is usually placed slightly above the crest of the bone. The soft tissue is then placed around the PME. The advantages of this surgery, the one-stage surgery, are: the soft tissue matures while the bone interface is healing. This permits the restoration to be fabricated with complete assessment of the soft tissue profile. In the two-step procedure, the soft tissue is less mature when the prosthesis is fabricated, as a stage 2 surgery is required to uncover the implant and place a PME or abutment, as we discussed. Another advantage: a second surgical procedure and suture removal appointment are not necessary. This saves the patient discomfort and the surgeon 2 appointments. Also, the abutment to implant connection may be placed above the crest of bone in the one-stage surgery. This higher location of the implant abutment connection may reduce some of the early crystal bone loss in a developing implant interface. As we can see here, the tissue is sutured around the PME during the initial implant surgery for a one-stage surgical approach. After healing, the prosthesis fabrication may be started. No second stage incision or tissue reflection is needed in this case. Here, the final prosthesis is delivered, and here, periapical radiograph of final restoration. Finally, a direct flapless one-stage surgery. The one-stage surgical approach may be modified with a direct flapless surgical approach. This technique does not reflect the crystal soft tissue. Instead, a core of keratinized tissue is removed over the crystal bone. The implant osteotomy is then performed in the center of the core of the exposed bone. This technique requires no suture around the PME. The advantages of this technique are similar to a one-stage surgical approach. In addition, there is less soft tissue trauma because the tissues are not reflected. As a result, discomfort, tenderness, and swelling are usually minimal. The primary disadvantage of the direct approach is the inability to assess the bone volume before or during the implant osteotomy or insertion. Therefore, this technique should only be used when the bone width is abundant, more than 8 millimeters. Thank you. See you soon.